Hello, everybody. Welcome you all in our webinar of today, EAVA Cardio Risk TME webinar. On behalf of the EAVA board, I would like to hope that you are all safe at home. Today with me Dr. Atif Al-Bahari and Dr. Hani Ragi, and I will let the stage to Dr. Atif Al-Bahari to introduce the program of today's webinar. Dr. Atif, تفضل.
Hello, welcome everybody to our EAVA webinar. Today we have three sessions. Each one is followed by questions and answers. The first session will be by Professor Dr. Ashraf Rida, PCSK9 inhibitor, lipid and non-lipid effects, which is followed by discussion, and then Dr. Hani Ragi, subclinical atherosclerosis, followed by discussion, and the last one will be dyslipidemia, key message by Dr. Ashraf Rida, followed by discussion. Now I introduce Dr. Ashraf Rida, PCSK9 inhibitor, lipid and non-lipid effect of PCSK9 inhibitors.
Thank you, Dr. Atif. So my presentation will be about PCSK9 inhibitors. We know that PCSK9 inhibitors have lipid effect, especially LDL reduction. But what about other lipoprotein particles? And what about if there is other than lipid effect, for example, effect on inflammation, effect on platelet, macrophage? We'll see the data about that. Of course, the main benefit of PCSK9 inhibitor in the trial is the high magnitude of risk reduction regarding LDL cholesterol level. And with, for example, here, evolocumab in the Fourier trial showed about 60% LDL reduction with 20% relative risk reduction and significant absolute risk reduction. This is regarding the primary endpoint and also the secondary endpoint, which are composite of cardiovascular death, myocardial infarction, or stroke. Let us first see a hint about the PCSK9 in our body. As you know, PCSK9 is a negative regulator of the LDL receptor. When it present and attached to the receptor, it leads to deactivate the process of recycling of the LDL receptor. So the complex of the LDL receptor, LDL and PCSK9, is now internalized into the hepatocyte and degraded, and there is no available LDL receptor to be recycled again on the surface of the hepatocyte. This is the LDL receptor with the LDL cholesterol and the PCSK9 protein attached to the receptor. So when attached, that means that the complex will be internalized and no recycling of the LDL receptor. So by the end of the day, PCSK9 protein in the body will decrease the amount of LDL receptor on the hepatocyte. If there is PCSK9 inhibitors that can inhibit this protein, this will allow the LDL receptor to be recycled again and again and again, many times, reducing significantly the blood LDL cholesterol. And if you look at the reduction of the LDL cholesterol that can be done with evolocumab in the Fourier trial, about 59% mean reduction with very significant p-value, and this reduction was maintained all over the follow-up periods of the study. This is another study showing the evolocumab low density lipoprotein cholesterol level less than 25 milligrams following evolocumab. Here on your left-hand side, the LDL cholesterol achieved with evolocumab treatment, for example, there is about 25% of the patient has LDL cholesterol less than 25 milligrams, and we have another number of the patient, for example, 10% of the patient have LDL cholesterol less than 15 milligrams. So this level of very low level of LDL cholesterol achieved whether in the Fourier trial or in the Odyssey trial actually raise an important issues about the safety and the efficacy and the effect of on cardiovascular endpoints and MACE. And actually, if you look at the adverse effects, there is no increase in the adverse effect compared to placebo. Maybe some cataract in some of the high dose of the histamine. Sorry. I'll try to present the second slide. Okay. So the first question now is it only the LDL that matters regarding the lipoprotein? Actually, as you know, we have other lipoproteins other than LDL cholesterol. And the question, what is the effect of histamine on, for example, HDL, non-HDL cholesterol, lipoprotein little a, and others? And if you look at the major statin trial the past decade, actually, despite significant LDL cholesterol reduction, we have an important residual risk. Whatever the trial for is, lipid care, HPS, and others, statin successfully reduce the risk from the gray column to the blue column, but still we have this blue column representing the residual risk. Maybe this is because we are not giving enough dose of statin. Maybe we are neglecting the other lipid particles like non-HDL cholesterol and others. Because as you know, we have in our body many lipoproteins, and LDL cholesterol is not the only atherogenic particle. HDL is the only protective one. So any lipoprotein particle other than HDL is should be atherogenic. This is called non-HDL cholesterol, and it is easily calculated. Total cholesterol minus HDL cholesterol equal this non-HDL cholesterol. So any ApoB containing particles like LDL, variable density, and chylomicron are considered acidogenic protein. If you look at the effect of histamine inhibitor on these non-LDL lipid particles, actually it leads to evolocumab in the Fourier trial lead to 51% of reduction in non-HDL cholesterol and 16% reduction in triglycerides compared to placebo. And this is actually very important because this will lead to decrease the triglyceride rich remnant lipoprotein, and this is actually, as you see, an acidogenic particle. It contains ApoB, it contains remnant cholesterol, it contains triglyceride and ApoB. Sorry, between changes here about some. This is also the effect of evolocumab on the ApoB proteins. And you know, ApoB, when you have a high ApoB in your blood, that means that the particle size is very small of the LDL cholesterol. So actually, reduction of the ApoB is one of the important. It is a secondary goal of therapy according to most of the guidelines. Also, evolocumab can increase the HDL cholesterol by 8.4%. When you decrease the ApoB lipoprotein, actually you change the LDL particle size to small particle size, and this is what you know as LDLP. And actually LDLP, or representing the particle size, sometimes or many consider LDLP is more important even than LDLC, which is LDL cholesterol, because the smaller the particle size, the more acidogenic is the lipoprotein. And if your ApoB is high, that means that the LDLP is high. Another important lipoprotein is the lipoprotein little a. And actually, lipoprotein little a is similar in structure to LDL cholesterol. The difference is that it has, in addition to ApoB proteins, it has Apo little a, which is genetically actually, if you have a high lipoprotein A, that means you have some genetic problems in this ApoA, and the higher the number of cankles K1, B1, the higher the acidogenicity of the lipoprotein. The problem of lipoprotein A is that it is not only atherogenic like LDL, because it is similar to LDL structure and function, but it is also due to this ApoA present had pro-atherogenic and pro-thrombotic effect because of the similarity with plasminogen activator inhibitor. So it actually lead to atherosclerosis in the usual pathology and pathogenesis like LDL. In addition, it can lead to pro-thrombotic effect by decreasing the plasminogen activation, blood permeability, and increase platelet response. Actually, fortunately enough, PCSK9 inhibitors can lower lipoprotein A, and this is some data from the Fourier trial showed the median change in lipoprotein A concentration at 48 weeks in the Fourier trial, about 26% reduction of the lipoprotein A. And if you know we have limited weapons or limited drug therapy or therapeutic options to reduce the lipoprotein A, and the most efficacy is apheresis. Of course, it is very high in nature, but it's okay that it is. Slide. And actually, there is a genetic relation between the level of PCSK9 protein in our blood and the lipoprotein A. And if you fortunate enough to have some variant of PCSK9 certain sequence in your blood, you will have a low lipoprotein A, and those patients with this PCSK9 variant characterized by low PCSK9 in the blood have low lipoprotein A and have low incidence, for example, of aortic stenosis and atherosclerotic cardiovascular disease. So actually, there is a genetic relation between the PCSK9 and lipoprotein A. Excuse me for the transmission. Every time I transmit the slide. Okay. So another question now is we discussed the lipid effect. Is it only lipid effect? Do you have other do we have other effect rather than the lipid effect? Well, let us look at this nice picture of the plaque itself. You know that inside the atherosclerotic plaque, there is an important role of the PCSK9. So it seems that PCSK9 is not only working on the hepatocyte in the liver, it is present in the atherosclerotic plaque, present in two forms, either circulating in the circulation around the plaque, as it is in the upper right-hand side, or from the bottom of the screen, it can release from the smooth muscle cell. So what can PCSK9 do in the atherosclerotic plaque? It can oxidize the LDL cholesterol. It can affect the macrophage and lead to the activation of the inflammatory mediator like TNF, interleukin 1B and interleukin 6, and so on and so. By the end of the way, it leads to T cell activation and T cell proliferation. So PCSK9 protein is not only working on the hepatocyte and LDL receptors in the liver, it is also working in the and have a very important pathologic effect on the atherosclerotic plaque, and that means that PCSK9 inhibitor actually may affect the atherosclerotic plaque and the inflammatory process in the atherosclerotic plaque. So if you wanted to summarize the effect of PCSK9 on the atherosclerosis, it will include, first of all, global effect on LDL metabolism through its effect on the hepatocyte, the LDL increasing the LDL receptor, reducing the LDL cholesterol in the body. But this is not the only effect. It has also local effect on the LDL metabolism within the atherosclerotic region itself, And more importantly, is what we call the pleiotropic effect on the other atherogenic mechanisms such as inflammation, lipid activation, smooth muscle cell proliferation, and migration. And this is actually very important and can explain the high efficacy of PCSK9 inhibitor in addition to lipid lowering to reduce the inflammatory pathological mechanism in the atherosclerotic plaque itself. Trying to, let us look at this possible preserved effect of PCSK9 and PCSK9 inhibitor. Actually, PCSK9 inhibition can affect the endothelial cell, can affect the platelet, can affect the vascular smooth muscle cell, and can affect the macrophage, and leading to many important effects, reducing the atherosclerotic mechanism. It can reduce the platelet reactivity and possibly reduce the thrombogenicity عن طريق maybe lipoprotein little a reduction. It attenuates also the pro-inflammatory state and it can reduce accumulation of macrophage. It may also promote the contractile phenotype of the smooth muscle cells and decrease the oxidative stress. So actually, this is widespread pleiotropic mechanism is very important and it can add to the effect of the benefit we can get from PCSK9 inhibition in addition to the lipid lowering effect. So in conclusion, dear colleagues, PCSK9 actually affects the lipid metabolism locally in the liver as well as systemically on the vascular endothelium and the atherosclerotic plaque. PCSK9 not only affecting the LDL cholesterol as regarding the lipid, it also affects the triglyceride, the non-HDL cholesterol, the lipoprotein little a. This is through its global lipid effect. So PCSK9 block also other atherosclerotic mechanisms by its pleiotropic effect through LDL oxidation, smooth muscle proliferation and migration, reducing the platelet activity, macrophage activity, and inflammatory activation. And I think this is a very important field for to explain the benefit of PCSK9 inhibition in our patients. So before I thank you, I will leave the stage to Dr. Atif Al-Dahari for some discussion about session 1 presentation. Dr. Atif.
Thank you very much, Dr. Ashraf, for your presentation. We understand there are two actions of PCSK9 inhibitors. I will focus on the pleiotropic effect and the inflammatory effect of anti-inflammatory effect of PCSK9. From a post-hoc analysis of the Fourier study, there were three high sensitivity C-reactive strata for patients with CRP, less than 1 or 1 to 3, and more than 3 milligrams per liter. They found that in both the primary and secondary endpoints, there is marked absolute cardiovascular risk reductions in patients with baseline high sensitivity C-reactive protein more than 3 milligrams per liter. Do you think this large absolute risk reduction in the highest strata with CRP was independent on LDL cholesterol lowering or a pleiotropic effect of evolocumab on inflammatory markers?
Well, this is a very good question, Dr. Atif, because actually it's clear that the higher the baseline high sensitivity active protein, the more is the benefit from lipid lowering with PCSK9 inhibition. This can go both ways. You know, LDL cholesterol, when oxidized, is considered by vascular endothelium as a foreign body, and it initiates a lot of inflammation around it. This is one of the important mechanisms of atherosclerosis. So reducing this oxidized LDL cholesterol and reducing this LDL cholesterol by its own can reduce the inflammation. In addition, that PCSK9 inhibitor, as we explained in the presentation, it has other effect rather than LDL cholesterol reduction by its effect on the smooth muscle and the macrophage and the platelet reactivation. So it can do this um, inflammatory reducing effect by the two mechanisms, by LDL reduction itself and by the non-LDL reduction, its pleiotropic effect on the other inflammatory mechanism.
I have another question, Dr. Ashraf, regarding the pleiotropic effect of PCSK9 inhibitor. Several clues suggest that the PCSK9 inhibitor may influence the platelet functions, reducing the aggregation and the blood coagulability. Beyond its strong LDL cholesterol reduction, is there a proof for that?
Well, there is animal study and some clinical evidence about this issue actually, which is the relation between PCSK9 inhibition and the platelet activation. For example, in the animal study, the PCSK9 knockout mice, that is mice without PCSK9, actually show an important effect on the platelet activity. If you don't have PCSK9 at all in your body, this is affect the platelet activity, and this is proven by the mice model for PCSK9 knockout mice. Also, there is some clinical data from patients with acute coronary syndrome, for example, who are taking P2Y12 inhibitors. And these patients, when receiving the PCSK9 inhibitors, the amount of residual platelet activity is less than placebo, and that was evidenced by in the clinical trial group analysis and sub-analysis of the patient. So actually, there is a relation between PCSK9 as a protein and the platelet activation, and consequently, PCSK9 inhibitor can beneficially improve this situation.
Thank you, Dr. Ashraf, and I think in the future we'll find many other effect of PCSK9 inhibitors, because this is the era of this clonal antibodies in reducing the atherosclerosis. Thank you very much. We will have a break for 1 minute, and then we will be again with Dr. Hani Raghi for his lecture, The Subclinical Atherosclerosis. 1 minute break up.
Okay. Good evening, everybody. Masā al-khair. I hope you're staying safe at home, and I would like to thank Professor Ashraf Rida, Professor Atf al-Bahari, and the rest of the EAVA board. And I would also like to thank the sponsors of this meeting, Amgen, and I'd also like to thank ICOM for the technology. You know, we gave them a lot of trouble. Marianne and Ahmed Yusri, really, really grateful, and to the rest of the team, of course. Thank you very much. I would like to take you where we have not been before, because we're going to go on a little trip outside the guidelines, but we're not going to be breaking any guidelines. We're going to be discussing what a group of us, and I'm proud to be a part of this group, through another organization called SHAPE, which is Stopping Heart Attacks, Society for Heart Prevention Eradication, on subclinical atherosclerosis. Because some of us think that very soon the guidelines will change, and I'll tell you why we think that. And we think that a lot of patients whom we consider now primary prevention are actually secondary prevention. So there's a very famous study, which is the PESA study. This was a publication in the JACC in 2017, in which participants, nearly 5,000 participants of the PESA study were studied to see, they chose participants without any, and they also had normal LDL, and they wanted to see if they had subclinical atherosclerosis. So there were 4,000 participants in the PESA cohort, and 1,779 of those, that's 42%, were without conventional risk factor. That's the conventional cardiovascular risk factor free population. Okay, And of those, 740 did not have risk factors and also had optimal levels of risk factors. So what did they find? This is very interesting. They found that anybody with an LDL above 60, okay, so even 70. So below 60, there was no atherosclerosis, okay? Above 60, you start getting, 2 to 3 sites. There's focal non-vascular site. That's no atherosclerosis in red. Gray is focal atherosclerosis of one vascular site. Orange is intermediate 2 to 3 sites, and blue is generalized atherosclerosis. That's 4 to 6 sites. Sites by meaning coronaries, peripheral vascular, carotid, etc. So look at this. As soon as you reach an LDL of 70 to 80, in the absence of conventional risk factors, you start developing atherosclerosis. And you even have atherosclerosis in more than one bed, 2 to 3 sites. With an LDL of 130, which you would consider pretty normal in many, at that time at least, a lot of patients had atherosclerosis, more than half the patients. And some of them had atherosclerosis, which was generalized, 4 to 6 sites. These are totally asymptomatic people with no known risk factors. That's normally a population which you would not screen. You would feel happy and you would reassure those patients. And this is the difference with the LDL again, and the carotids are in blue. The aorta, atherosclerosis in the aorta is in orange. The iliofemorals are in gray, and coronary artery calcium scoring, that's coronary artery disease, subclinical coronary artery disease with atherosclerosis and calcification, is in red. Starting from an LDL of 80 to 90, everybody had coronary artery atherosclerosis, okay? Every single, all of them. The only people who did not have atherosclerosis, subclinical atherosclerosis, were those with an LDL of 50 to 60. These are remarkable findings. And this study concluded subclinical atherosclerosis is present in 1/2 of middle-aged PESA study individuals without major cardiovascular risk factors, and then 1/3 of those in the cardiovascular risk factor optimal subgroup, suggesting that additional factors are involved in this development of atherosclerosis, and that LDL cholesterol at levels currently considered normal is independently associated with the presence and extent of atherosclerosis. These data provide strong evidence of a unique independent role of LDL cholesterol in early human atherogenesis. And these findings will have important implications for guiding primordial prevention and understanding the mechanisms underlying atherosclerosis. We are going to be using this data to go to a totally different level of primary prevention. We have what is called total period, فترة سماح, where atherosclerosis starts developing before we start getting events. What we are doing at the moment is we're actually waiting for an event to happen and then doing secondary prevention, or screening people with known risk factors for primary prevention. But this study has shown us that those without known risk factors, I'm sorry, my cat keeps coming on my lap. Atif was asking about it. Anyway, so those without risk factors are to be screened as well, because that is where you might be able to do this primordial prevention. So how do we do that? I mean, are we gonna calcium score everybody, or are we gonna Doppler scan everybody? Maybe one day in the future. But what about the clinical? We're clinicians and we like clinical ways to find things. So how do you predict subclinical atherosclerosis in low-risk individuals? This is a phenomenal paper by a group which includes the legendary Valentin Fuster, who is one of the fathers of subclinical atherosclerosis detection. And as we know, his status, and he's the editor-in-chief of the JAC, of the American College of Cardiology, and he lives in New York. He's originally Spanish, and he's really one of the fathers of modern atherosclerosis and modern cardiology. This was, again, a relatively recent paper in 2017. And Dr. Fuster wanted to share with us how to predict subclinical atherosclerosis in low-risk individuals, and then we go ahead and screen them. So basically, they did a Fuster and somebody else's components of the PESA study. So they looked at actually 5 clinical parameters. They looked at the blood pressure of patients, at the exercise level of the patients, at the weight of the patients, at the diet of the patients, the tobacco status of the patients, and then they found a number of ideal metrics. So they had the ideal metrics, and they had, as patients got higher blood pressure, they became worse. As they exercised less, they became worse. As they had a higher BMI, they were worse. Statistical significance. As they ate less fruits and vegetables daily, they were worse. And as they were current smokers, they were worse. And the more ideal parameters you had, the less subclinical atherosclerosis you had. So there are clinical scores which you can use to try and predict which patients will have subclinical atherosclerosis. Dr. Fuster and his colleague compared 2 scores. One of them was the ideal clinical heart score, and the other one was the Fuster score. And the difference between both is that the ideal clinical one requires lab tests. So it requires that you know fasting blood sugar, while the Fuster score is completely clinical. And actually, both were pretty similar in identifying subclinical atherosclerosis. This is the Fuster score, and this is the ideal clinical heart score, in identifying patients who had free of atherosclerosis in blue, had focal atherosclerosis in orange, intermediate atherosclerosis in gray, or generalized atherosclerosis in red. Pretty similar prediction rate between both scores. So the ideal clinical heart score, which incorporates 7 metrics: exercise, body mass index, diet, smoking status, blood pressure, and then 2 lab works, which are blood cholesterol and fasting glucose levels, has validated predictive value for cardiovascular events. And the Fuster BWAT score uses 5 of those metrics without laboratory tests. Both scores exhibited comparative predictive values for detection of subclinical atherosclerosis in healthy individuals. These are people that you're not. And with the Fuster score, you don't even need to know their cholesterol levels. So this will give us a translational outlook, because this Fuster BWAT score is an easy, painless, inexpensive tool that could be implemented in resource-constrained healthcare settings, to identify individuals with high likelihood of subclinical atherosclerosis, in whom preventive management strategies are directed. I'm happy to tell you that with Professor Ashraf Rida and Professor Atif al-Bahari and the EAVA board, we're going to discuss a study in which we simply screen patients using the Fuster BWAT score, which does not require anything, does not even require a lab test. And then we will identify those at high risk for subclinical atherosclerosis and possibly screen them with a cheap way of imaging and maybe come up with some Egyptian data. So the use of scores in assessing cardiovascular health behaviors is useful for predicting the presence of subclinical atherosclerosis in healthy adults at low short cardiovascular risks. The patient waiting in your office room can fill a little piece of paper with 5 points, and you would know how their score. And those 2 scores were similar, but one of them is simpler, does not lead laboratory results, and maybe consider the first option in settings where you can't perform widespread laboratory tests. Based on that, in the same year, in 2017, the idea of primary prevention of atherosclerosis started developing, and a major editorial by Nambi and Butt on taking a selfie, taking a picture of yourself for the primary prevention of atherosclerosis, because that is where we work now, okay? That is where we work now, but we want to start working here. We want to start when there is only subclinical atherosclerosis by doing primary prevention, changing behavior and the environment. We can't really change the genes at the moment. There are ways of detecting this subclinical atherosclerosis by scores, by genetic markers, by biomarkers, and by imaging of carotid ultrasound, and by imaging of the aorta, and by imaging of coronary calcium scores. Any patient who's going to undergo any CT of the chest should have the aorta looked at, even if that's not the primary cause of the CT. The same if they are going to undergo an abdominal ultrasound. It will take the ultrasonographers 2 minutes to look at their carotids. We don't want, so we can actually change the way we practice if we start looking for subclinical atherosclerosis. And this was the editorial which said that our definitions of normal or optimal for various risk factors have been evolving. Everybody in the attendees remembers when the normal LDL was 160, and now the normal LDL is below 55, is above, anything above 55 is high in atherosclerotic cardiovascular disease. So our levels were geared to provide the management of atherosclerotic cardiovascular disease. Till now, we do not have normal levels to predict the development of subclinical atherosclerosis. For example, the efficacy of statins in both primary and secondary prevention of atherosclerotic cardiovascular disease, which led to revising the optimal values in healthy or diseased patients, and recently intensive lowering of LDL from 70 to 50 when SDMIB was added to statin therapy was shown to reduce incident atherosclerotic cardiovascular disease. And furthermore, the addition of PCSK9 inhibitors favorably altered atheroma on IVUS and reduced the atherosclerotic cardiovascular events while reducing LDLs of about 30 milligrams per deciliter. And all these data have resulted in a discussion of how low an LDL target should be in secondary prevention of atherosclerotic cardiovascular disease. But in this context, the paper I just showed you, which is the analysis of Fernandez Ferreira and Fuster, is highly relevant and now raises an important question. What is the optimal cholesterol level for the primordial and primary prevention of atherosclerotic cardiovascular disease? We do not want to wait and start secondary prevention. It will be much, much better to do a primary prevention. At this point in time, the main reason why primary prevention has not taken over, it was because of the cost effectiveness. It costs a lot of money to prevent atherosclerosis in a patient who's 30 years old, and people look at them in a wrong way because they calculate their 10-year risk. Do you really want that patient to get atherosclerosis when he's 45? We should always be looking more at lifetime risk. Looking at the 10-year risk is tricky in young people. You should look at the 10-year risk in the older individuals. So if somebody's 70, yeah, I'll look at this 10-year risk. But why would I look at the 10-year risk of a 30-year-old? And after 10 years, he's just going to be 40 years old. In summary, this elegant analysis shows that subclinical atherosclerosis is highly prevalent, even in normal values for conventional risk factors. Brings the question defining normal and primordial and primary prevention, and for that matter, the definition of what is a primordial prevention. The management of atherosclerotic cardiovascular disease is conventionally focused on secondary prevention or short-term 10-year primary prevention. But just as I discussed, the findings from the current analysis underscore the need to start using advances in imaging, in biomarkers, genetics, and risk scores to re-examine the definition of optimal cardiovascular health. Given the significant lead time, الأفانس اللي أنا مديهولك, that atherosclerosis affects us as a community, it may be time to take a selfie of not only our own arteries, but our own approaches to primordial and primary prevention of atherosclerotic cardiovascular disease. So we should look at the 20 or 30 years period of time in which we're leaving atherosclerosis to devour the vascular system of people before we intervene, and that is a golden time frame to intervene. This was again an important paper, but this was in 2019, which was by Armin Zadeh and Valentin Fuster, again, Dr. Fuster shines, which wanted to show us how the world has changed from trying to find the 2-centimeter plaque to stent it, to manage the entire patient, to manage the whole vulnerable patient, not just the vulnerable plaque. And it showed us the famous finding that before a STEMI, before a STEMI, the angiographic stenosis in 50 consecutive patients, actually not before a STEMI, before sudden cardiac death, those people actually died and underwent an autopsy. And in this paper from Farb and his colleagues, the majority of the patients did not have very critical stenosis. So atherosclerosis was then thought to be possibly fatal, even when you don't have severe atherosclerosis. This paper, because it's post-mortem, would actually ignore the concept of vascular remodeling in the assessment of normal lumen and would not be extremely accurate if it was undertaken in vivo when the patients were alive, and I'll discuss that in a moment. Sorry. Oops. Let me just take you to where I was. I'll be with you in a second. Yeah. Yeah. Okay. So sorry about that. And another important paper looked at the patients who died, okay, or had a myocardial infarction, and compared three groups: a group which had no coronary artery disease and no ischemia, which had very little rates of death or myocardial infarction, and a group which had no coronary artery disease by imaging, but were ischemic, okay, by means of detecting ischemia like SPECT and clinical picture. And they also had a very low incidence of death and myocardial infarction. It's only when ischemic patients have atherosclerotic cardiovascular disease, coronary artery disease, that the rate of death and myocardial infarction gets high. This was the WISE study, which is the Women's Ischemia Syndrome Evaluation, which showed us this group which had inducible myocardial ischemia but no coronary artery disease on imaging, compared to the patients who had coronary artery disease, regardless of having ischemia or not, had more death and myocardial infarction. So this again shows us the importance in a period of 3-year follow-up of atherosclerosis and coronary artery disease. These were similar studies on carotid plaques of patients dying of non-cardiac causes, and the more atherosclerosis you had, the more plaque rupture and erosion on autopsy, even if the death was non-cardiac. And this is the famous central illustration, which was that in the 80s, we were so happy to put a stent in a disease segment of 2 millimeters, while now we're actually looking at the ischemia, like the ischemia trial patient. We're not looking at lesions anymore. We're actually patient-centered. We're looking at medical treatment to treat the entire patient, because it's not just a plaque which is vulnerable. This entire patient is vulnerable. And we should try to reduce the risk factors. We should try to get them to stop smoking. We should try to give them medications, and not just treat a plaque. I'll go quickly about, this is how we were looking at atherosclerosis in the 80s and even in the mid-19th century. When we started thinking there was an inflammatory reaction. In the 80s, we started to discuss smooth muscle migration to the plaque. Here in the 70s and 80s, and adaptive mechanisms. Lipid storage was discovered between 1900 and 1970, and now in 2020, it's actually all our history from all those times, from the early times when we looked at the role of inflammation to smooth muscles, till we realize. And we now realize that for atherosclerosis to lead to events, we need to also look at the morphology of the plaque, not just its size and not at the remodeling. We need to attack the thin fibrous cap full of inflamed lipids, which can crack and lead to thrombus. And this can happen in multiple sites in the body. Yeah, okay, so I'll move quickly. Most coronary events result due to plaque rupture. You need to have plaque rupture, and you can prevent plaque, and you need plaque progression. So even lesions which are mild progress before, and this is an example of عكس الناس كلها متصورة. This is an artery where the stenosis seemed to get less, but it was actually getting a thinner fibrous cap, and the artery looked bigger because of positive remodeling. This is worse. This is progression. On the other hand, if the artery does not get bigger, but statins lead to calcification of this cap, this is actually regression of the plaque, even though angiographically you might think it's worse. And these data are data by Iverson Coronary Angiography. This is my last slide, is that we have moved from the era of focal treatment of atherosclerotic plaque to an era of treating atherosclerosis medically as a disease. We rely on detecting atherosclerosis and preventing a second event. But in primary prevention till this time point, we relied on treating individuals with risk factors. We should, and we are entering an era of detecting subclinical atherosclerosis and starting primordial and intensive primary, and I would call it a secondary prevention, but secondary before an event, but after atherosclerosis has treated. We should treat this disease before it causes events, because we now have the tools to diagnose that. We now need the guidelines and the policies and the fundraising. Thank you very much, and please stay safe. Okay.
Thank you very much, Dr. Hani Raghi, for your very, very substantial lecture. I have a question for you. Please. Do you think plaque positive remodeling predicted MACE better than 10 years from Graham score, risk score, or coronary artery calcium score, or 2-dimension or 3-dimension ultrasonography?
Yeah, I mean, not in the short term, but imaging, as we well know, I mean, calcium scoring, for instance, and carotid imaging does predict events, but it predicts events in a longer period of time. The beauty of this is less in predicting events, more in actually giving us a window of prevention, which we did not have before. So you could now screen, for instance, let me give you an example. Suppose you have somebody who's had a coronary artery disease in their family before the age of 50 and is following a very healthy lifestyle with an LDL of 120 or an LDL of 150. And you don't know what to tell them. You tell them, okay, go ahead, good luck. Or would you image them for the disease? I would propose now, but this is still not in the guidelines, but I would actually propose imaging for the disease, even with a simple carotid duplex. Now you have the big question, the elephant in the room. If you find that they have significant atherosclerosis at this young age, with no events and with an LDL of 150 and with a family history of cardiac conditions before the age of 50, I would treat this patient. I would treat this patient. I would bring the LDL down. I would consider that this is already existing atherosclerotic cardiovascular disease. This patient for me would be a class 1A for high dose statins, or at least for a target of below 70, and possibly, if you're aggressive, even below 55. And you can use all the tools that you have, whether as azithromycin or even PCSK9. If this is not in the guidelines now, we expect that it will be in the guidelines soon. This is, anecdotal, but as you saw, it's supported by science from many studies in the Journal of American College of Cardiology, adopted by, nonetheless, Valentin Fusser himself.
So, Hani, if we have patients with 70 milligram per deciliter LDL cholesterol
Yes.
It means he have now subclinical atherosclerosis. If we detect that, we have to start statins from this, and we hope that all the laboratory in Egypt make that in mind, because they still put the figures very high, and this is assures our patients, and this is can be wrong.
Yes, I actually want to go back to this slide. I don't know if my slides are still on the screen or not, but this slide is extremely important because it shows what lipid reduction therapy does, what statins or statins and ezetimibe or PCSK9 does. It actually stabilizes those plaques. So even if the artery undergoes negative remodeling, and even if the plaque seems more occlusive, or even if the plaque causes angina, it will be stable angina, because and calcification occurs in those plaques, and they're much less likely to rupture and cause events. And what kills patients and what hurts patients is plaque rupture and plaque progression before events. What we want to do is we want to lead to plaque regression and to calcification. In this panel, if the artery undergoes positive remodeling, but the plaque is thinner and is more inflamed and is more likely to rupture, and these are the types of patients that were found in the famous paper where they seemed like milder lesion. It's a trick. And this is in the recent paper in JACC in 2019 by Amir Ahmadi and Valentin Fusta. And I would love to share it with you.
Thank you very much, Dr. Hani. And now we will go back to Dr. Ashraf Rida for his last presentation.
Okay, so the session 3 will be about the dyslipidemia guidelines. Of course, we will spoke with some focus update on the PCSK9 inhibitor. Actually, most of the world using a lot of guidelines, mainly the ACC/AHA guidelines, the American Endocrinology Group, and lastly, in since August 2019, EAS and ESC. Of course, every country and every region should have the local guidelines, depending on the availability of therapeutic options, depending on the risk scoring or risk factors prevalent in the local community and the high risk of their population. So we'll focus on the European Society of Cardiology, European Atherosclerosis Society guidelines, and of course we will not go through all the details of the guidelines, but I will, in the following presentation, concentrate on these points to discuss. Let us first discuss the risk category and the new LDL goal. And actually, this is one of the main changes in the guidelines. And this is central illustration showing the idea of the guideline in general is to risk stratify the patient before taking the decision what to do. The new in the guidelines is that we have new numbers, we have new goals of therapy, especially in very high patients, very high risk patients, which become now less than 50 milligrams per deciliter and 50% reduction. So now you have both. I want to emphasize here in this picture that even those at low risk with a score less than 1%, the goal is 116 milligram per deciliter. So sometimes even low risk patient may need some therapeutic intervention. So as a whole, we have to risk stratify our patients. We are not depending much on the baseline LDL cholesterol. It is okay. We determine the baseline LDL cholesterol to follow the patient. But the number is not as important as the risk of the patient in deciding whether to treat or not. Of course, except those with familial hypercholesterolemia and very high LDL cholesterol level above 190 or above 100. Can we achieve this goal? This is very, very low goal now. It's become a difficult task for most of us. And if you look at this paper with centralized pan-Middle East survey on the under-treatment of hypercholesterolemia, the CPS trial, which was done with the same protocol in many European, Middle East, and North African countries. If you look at the, for example, the results of Egypt compared to the other geographic parts, we are the worst. Our percentage of goal achievement is 32% in all. This includes all the patients risk categories, low risk patients, high risk patients, and so on and so on. If you compare in the Middle East as a whole, it is 52%. In the Western Europe, it is 57%. So we need a lot to do in our patients. And if you look in some detail to the graph on your right hand side, and we categorize the patients in very high risk and other risk. It is even more worse in those with very high risk, that in which the level of goal achievement is less actually than 11%. And this is very actually bad situations, because maybe the reason is that at that time, 2014, 2015, we are accustomed to give the patients a small dose of statin therapy and then follow the LDL cholesterol, and if it is high, increase the dose. That's why in the Egyptian consensus of dyslipidemia management that was launched in 2017, and actually with the participation of Egyptian Association of Vascular Biology and Atherosclerosis, EAVA, Egyptian Society of Cardiology, and CD of Alexandria. This local consensus actually based on the low percentage of goal achievement that was clear in the CEPHEUS trial, decided that the best way is to use the goals of therapy. Goals is very important. We have to follow our patient goals, and we have to use the ACC/AHA guidelines in that to start high intensity statin therapy if your patient has it. So at that time, we decided that it is the best way in Egypt is to start high intensity statin, but in the same way to have a goal of that. The other issue in the European guidelines is about the familial hypercholesterolemia, because actually familial hypercholesterolemia, especially heterozygous familial hypercholesterolemia, is not a rare situation. If you look at the Egyptian Cardio Risk project about the risk factor profile in our patient with acute coronary syndrome, one of the striking results is that the mean age of the population with acute coronary syndrome, we are at least 10 to 12 years younger, our patients, than those compared to Western countries. So our patients are younger. Our patient has multiple risk factors. The onset of acute coronary syndrome in our population at young, and I'm sure this is present in other Middle East and Gulf area. The reason for that in this study was, number one, high prevalence of smoking. Number two, the prevalence of multiple risk factors and the possibility of heterozygous familial hypercholesterolemia in many of these population with premature atherosclerosis. And actually, only 7% of Egyptian males and more than 60% of Egyptian females presented with acute coronary syndrome are considered premature atherosclerosis. And these results was included in an important paper published in Atherosclerosis about the overview of the current status of familial hypercholesterolemia in over 60 countries, the FHSC study, and it's quoted in the paper about that the preliminary data from the Egyptian Cardio Risk project showed premature atherosclerosis in a high percentage of patients, and probably half of them may have heterozygous familial hypercholesterolemia. Of course, you will not know that your patient have familial hypercholesterolemia except if you put him in one score or another. And this is a Dutch Lipid Clinical Network score, depending on the family history. If you have first degree relatives, for example, with premature atherosclerosis, the clinical history of premature atherosclerosis deserves 2 points. Physical examination like tendon, then soma, maybe 6 points. And lastly, the LDL cholesterol level, and according to the level, you can get 8, 5, 3, or 1 point. DNA analysis, of course, if it's available, will be diagnostic. Anyway, if you put your patient on this or other risk scoring system for familial hypertension, you will find that many of your patients with premature atherosclerosis are actually cases of heterozygous familial hypertension. So, what is the European guidelines tell us about the recommendation for detection and the treatment of patients with heterozygous familial hypercholesterolemia? I think you can expect familial hypertension if you have a patient with atherosclerotic cardiovascular disease prematurely, less than 55 years in age and 60 years in female. If he has relatives with premature atherosclerotic cardiovascular disease, if there is relatives with tendinoblastoma, and of course the LDL cholesterol is important, especially if it is above 190 milligram for adults or above 150 milligram per deciliter in children. So in this situation, you have to expect and you have to screen for familial hypercholesterolemia. The third point, the guidelines, is about acute coronary syndrome. And actually, there is some changes in acute coronary syndrome patients. First of all, it is class 1 indication, of course, to start high-intensity statin therapy to those with acute coronary syndrome, regardless of the baseline LDL cholesterol. They emphasized also that it is not enough to start statin therapy in the hospital. It is very important to follow up your patient 4 to 6 weeks after discharge to monitor whether you are at goal or not. And if you are not at goal, the guidelines tell us that we can start adding ezetimibe, and if not at goal, we add PCSK9 inhibitors. And actually, I think adding ezetimibe, it's based on the improved trial, of course, but we don't have any randomized trial to tell us whether starting with ezetimibe as the second step is better or starting PCSK9 as the second step is better. I'm sure that we are, all of us, choose starting with ezetimibe because of cost issues and cost effectiveness. We'd like to give the patient chance, maybe he reach the goal with combination. Other important situation in which the LDL cholesterol goal may be even less than 55. Here the recommendation is sometimes you may need the LDL cholesterol of your patient to be less than 40 milligram per deciliter. And this is, for example, if the patient with atherosclerotic cardiovascular disease experiences a second vascular event within 2 years, whether one of them is ischemic, coronary, one of them is stroke, 2 attacks, and here it's class 2B indication to have your goal to be less than 40 milligrams. And I'm sure this is very, very aggressive, lowering the LDL cholesterol, and you could not achieve this goals except with a powerful therapy. We will try, of course, high intensity statin blockers to manage first, but I'm sure many of these patients will actually need PCSK9 inhibition. And that's why the issue of acute coronary syndrome is so important. I have the honor to lead a group of experts from non-Western, non-North American countries to examine the situation in our countries about goal achievement, about acute coronary syndrome, barriers of treatments, barrier of reaching the goal. And that paper was published very recently, narrative review and expert panel recommendation on dyslipidemia management after acute coronary syndrome in countries outside Western Europe and North America. And this that includes Colombia, Brazil, Taiwan, South Africa, Egypt, Israel, and Emirates. The fourth point I want to discuss with you in the guideline is the combination lipid modifying therapy and the new PCSK9 inhibitor positioning. I think it's era of combination therapy in dyslipidemia management. One drug may be okay, but usually you may need combination in many situations. Of course, this PCSK9 inhibitor, the main drive for putting them in many indications is the cost effectiveness. However, if from the clinical trial point of view, you should give PCSK9 inhibitor to any patient who failed to reach the goals, regardless of high-intensity statin therapy or combination therapy. Of course, for primary prevention, because of the cost and because of the evidence, it is class 2B. However, in secondary prevention, actually, especially those with very high risk patients, it is class 1 indication to give PCSK9 inhibitor to these patients are not at goal. Also, patients with familial hypercholesterolemia, the very high risk patients with familial hypercholesterolemia, why when will be familial hypercholesterolemia very high risk? If you have atherosclerosis cardiovascular disease or other risk factors, it's class 1 indication to give PCSK9 inhibitor. And actually, because the situation in each country is different, we have published recently the Egyptian consensus on the use of PCSK9 inhibitor. Of course, you are trying always to put the PCSK9 in the very higher risk group, to be just because of effectiveness. And I can summarize this is that we recommend patients not at goal with maximum intense lipid modifying therapy if they have especially if we have post-acute syndrome, premature atherosclerosis, familial hypercholesterolemia with atherosclerotic cardiovascular disease, diabetic with atherosclerotic cardiovascular disease. Of course, any very high risk category will deserve, but this is the I'm sure we have knowledge gap and research needs in the era of PCSK9 inhibitor and acute coronary syndrome, especially comparing starting PCSK9 after statin therapy or wait after failure of PCSK9. The last point in the guidelines is the lipids and other than LDL cholesterol. They are important. Non-HDL cholesterol is secondary goal. ApoB should be a secondary goal. Actually, triglyceride, we have no goal for triglyceride, but it is preferable to be less than 150 milligram per deciliter. And I want to remind you that even in the Fourier trial, evolocumab, one of the inclusion criteria is not only LDL cholesterol not at goal, but the inclusion is LDL above 70, non-HDL above 100 deserve PCSK9 inhibitor and benefit from PCSK9 inhibitor. Lipoprotein little a is very important. It is a genetic disease. We can screen lipoprotein in at one's life and then according to the level of the lipoprotein little a. Because actually it is related to myocardial infarction, and in the general population, those with higher lipoprotein little a have higher myocardial infarction. Lipoprotein is also related to heart failure, either through atherosclerotic cardiovascular disease or through aortic stenosis. And actually, we have limited therapeutic options. Statin has no effect. Niacin may reduce it, and PCSK9 inhibitor fortunately can reduce lipoprotein A by 25 to 30%. Lastly, I hope I covered some points from the guidelines, which I think it was very important and emphasizing our patients at risk with different risk categories. And thank you. And I will leave the stage to Dr. Atif for some discussion questions. Dr. Atif.
Thank you very much, Dr. Ashraf, for your illustrative lecture. It's only one question for the sake of time. We know in the post-hoc analysis in the Descartes study using evolocumab, patients with LDL was more than 70 milligram per deciliter, and the fasting triglyceride was less than 100 milligram. This study showed that there is significant changes in the lipoprotein particle numbers and sizes. The total LDL cholesterol is decreased, small LDL particles are decreased, and the large LDL particles are decreased. And could these findings help guide our therapeutic decisions in very high-risk patients, for example, in diabetic patients and in recurrent MI?
Thank you, Atif, for the questions. And of course, I agree with you that we need a lot of what I say modifiers or risk enhancer to put PCSK9 inhibitor in patients. Because
Yes.
if we follow the clinical trial, I think it is indicated in any patient, any high-risk patient who are not at goal. But these points can be used actually in this area. If you are in doubt and the LDL cholesterol is not very high, it is 70 or 65, you check the ApoB. If your ApoB is high, that means that the particle size is small. That means that your patient is still at risk. And here, don't be reluctant in getting your patient from 60 high, very high risk patient, of course, from 65 to 55 or less than 50 milligram. And don't say that it's enough for this patient because this patient is still at risk. So ApoB may be a risk stratifier to help you in taking a decision in certain situations.
At the end of this webinar, I'd like to thank Professor Ashraf Rida, Professor Hanragi for sharing this EAVA webinar. I'd like to thank Amigen for the support and for the sponsorship. I'd like to thank ICOM team for their technology for transmitting this webinar. And thank you very much and have a good day. Stay at home. Thank you.
Bye.